In the future, the norm for healthcare will likely be artificial intelligence working alongside humans. I talked to Dr. Ami Bhatt about what that kind of human-machine collaboration looks like.
Dr. Bhatt is the Chief Innovation Officer for the American College of Cardiology. She's also the director of Massachusetts General Hospital's Adult Congenital Heart Disease Program, working on state-of-the-art interventions. Dr. Bhatt first started working on virtual healthcare over a decade ago.
Key about practicing with young adults is when they're 24 and people do FaceTime, they think, why can't I FaceTime with my doctor? Because they didn't all live in Boston. They weren't down the street from Mass General or Harvard. And so they would come from hundreds of miles away and they'd say, but Dr. Bhatt, can't we just FaceTime? And I'd say, no, I think that's illegal. We can't do that. And right then is when telemedicine was starting. And so I asked, and Mass General was kind enough to say yes. I said, can I try telemedicine? I know that we don't do it, but I'd like to try it. And so 2013, I started doing telemedicine. I ran a clinic every Wednesday for the subsequent 10 years. And my patients from far away would just love to connect with me online, in addition to the times I needed to see them in person. And so that's really what drove me to start thinking about healthcare at a distance, providing care in the communities where people live. And I think that's the essence of telemedicine and digital health.
In her current role as CIO, Dr. Bhatt works on healthcare innovation and the future of digital health.
We are going to we are going to demand that we see a human that we can interact with clinical acumen, and a human that is working with artificial intelligence to ensure that all the data that is out there in science is being used to help us achieve the best outcome.
Medicine and technology, they evolve. And as a doctor, you have to evolve with it. And it's easy to get kind of stuck in where you're at. Talk to us about the environment and what you're up against there.
Yeah, I think what you said first is most important. The amount of knowledge that we have has changed exponentially. So just what we know in science is so different now than it was 20 years ago when I started practicing, which is different than 2 decades prior. There was a time when, in the 1970s, you could only get medical knowledge in books at the library. And when you went to see your physician or nurse, they were the only ones who had that knowledge. Now we have so much more knowledge available. We have more publications, more books, but we also have now information about the patients. We have their wearables. We have their electronic health record data. We have so much additional social demographic information that we recognize is important to their health. And so when we talk about how to adapt, what we realize is, as a clinician, my brain does not have the computing power to take all of the scientifically rigorous knowledge that's out there about, let's say, you, my patient, and be able to synthesize it, source it, synthesize it, and then apply it to you in the 20 minutes that I have with you in an office. And so I think that's where we're being almost forced, but not in a bad way, to adapt, which is if I want to provide the best care, and that's what any clinical person wants to do, and you want to receive the best care, both of us want the information at our fingertips, and we have to rely then on things like artificial intelligence, things like generative AI that can pull that data and present it to us, so then I can use my nuanced experience and I can listen to you and your words rather than doing the computer. And now we have a real conversation. So I think we're being forced to adapt. Healthcare is not accepting AI and digital health because there's some external force. It's an internal force. Our ability to care for patients is much better than what we're achieving in the old school way.
There's so much fear out there associated with AI. AI is going to take over this job or that job. It's not like AI's my doctor. It's going to be my physician and AI collaborating. It only makes the doctor that much stronger, right?
That's very true. But I will say there are some areas where if you want to provide high quality health care early on in disease, right? Preventive, early disease in the communities where people live, we need to aim for a place where if your blood pressure is a little high for your own baseline, right? Not the global baseline of blood pressure, but if I'm measuring your baseline blood pressure at home and it goes a little high, there should be some relatively local closed loop, whether it's a pharmacist, a community health worker, the local primary care, who can take a look and say, yeah, let's increase that medication a little bit and continue to measure you continuously, not sporadically once a year, that kind of work, I think, is going to be 75% automated, 25% clinician observed, because that's very early disease where we don't need you to drive 3 hours to the city to see the cardiologist because your blood pressure is a little high. You need me for the more severe diseases. You need me for the things where we really have to think about it. And ideally, if I'm caring for you in the community using some of these automated, with a little bit of clinical supervision systems, if we can build them right, then we get to a place where you may not get that severe disease. You may not have that stroke because we were following you in the community where you live.
The COVID-19 pandemic helped push the adoption of digital health. In the United States, the government made regulatory changes to its Medicare program that provides health insurance to people 65 and older. Those changes meant more people were no longer bound to in-person doctor's visits to get coverage and could get access to telehealth services.
We started with only 6 hours of digital health programming through all of CES years ago. And now every day there is programming and there are new companies on the floor. So we've just evolved so much in the past 5 years. But what we think about is the healthcare of 2035, it's possible today. Our job is implementation. And what we're not used to in the practice of clinical medicine is iteration. We don't iterate while we practice, right? I can iterate and say, this is not the right medication for you, this is the right one. But I don't change how I care for you. We've never asked people to do that. So we need to figure out the infrastructure and the workflows to be able to say, I'm going to take all this data from all these great companies and incorporate it into how I think about your health. We have to teach people how to do that. And to teach, we need to build it first, the infrastructure for bringing in all this cool data, AI, digital health, and figure out where it fits in the infrastructure of healthcare. That's our next job. That job needs to start now.
It's interesting, though, when you talk about change, I always think that really smart people are more adaptive to change. And that's not actually true. I worked in a newsroom where all of a sudden everybody's talking about, oh, we got to get it on the internet, and that's coming. And so you as a print journalist, you need to go out and do this. And then it's like, no, we've never done it that way. I'm not doing it that way. And I think about older staid doctors. No, I've always done it this way. This is a revolution. Can you talk about that aspect of it? Because not everyone's going to embrace it, right?
Yeah, we lost a good friend and cardiologist recently, kind of world-renowned cardiologist. And when COVID first happened, he wanted to try telemedicine. He knew that he wasn't great with electronics, but he wanted to try it. My 16-year-old daughter was his at-the-elbow help. She was on the phone with him, helping him log in and figure it out. And he always used to say, yes, change is hard, but if you remind people what they want to achieve, and that's a connection with their patient and good health care, then they'll realize that some of the newer tools are going to help them achieve that better. But you have to go back to ensuring they understand you're not doing something to them, you're doing something for them. So yes, change is hard. It's hard for older and younger people. Most people don't want to change. It takes a lot of effort. But if you remind people what their end goal is, and you show them that the technologies are helping them get there, I think we'll get, a majority of people to be able to use the new technologies and enjoy using them.
Work, education, and our social lives went online during the pandemic, putting even greater emphasis on the digital divide. An estimated 2.7 billion people, or 1/3 of the world's population, are not connected to the internet. That's according to the UN's International Telecommunication Union Agency.
We talk about new technology and how it's going to revolutionize things, but we think about income inequality, and there's already talk about a digital divide. There's going to be marginalized communities that probably won't get access to this. How do we change that landscape, and how do you address that?
Yeah, we're not alone. So if you look at education, let's take the United States, for example. The field of education recognizes that as they start doing more digital education, they have a divide. And they need broadband as much as we do. So I think one thing we can do is unite across all the different disciplines who are dependent on getting some form of care, education to the communities where people live and help understand how to build it better. Now that's a very big goal. So what are the small goals in medicine? If I'm going to capture data from you, when I capture data from you, I should make sure to only transmit it at night. I should make sure to have a local way to store it and only send it when you are actually connected and not demand that you have to be connected all the time, right? You may share the same iPad for your kid to go to school and for your healthcare. So the hours at which you're transmitting data are going to be different. We have to understand that and accommodate to it. So there are small changes we can make to ensure that the most at-risk communities that, mind you, have access to phones and tablets, and they do. It's not that there aren't any there. It's that the connectivity is limited. The timing may be limited. The cost may be prohibitive. What can we do as healthcare to help ensure that they're getting care in the community where they live? Why do they need it? Those communities are likely hourly wage workers. You can't take 4 hours off to come to the big city and wait and pay for the garage parking or get a ride and get childcare and elderly care at home. All of that is much more complicated than getting you a digital device and being patient with how we store and upload the information and respond to you.
Talk to me about VR, because I've heard you talk about that too. It's an exciting aspect as well.
It is a great field. So my husband is the first one who taught me about kind of video games and VR, so I have to give him a shout out. Today's his birthday. Having said that, I think the great thing about VR is not the gaming concept. The great thing about VR in healthcare is we know that especially for procedures, the more procedures you do, the better you become, period. If we think about the population you just asked me about, where we need to get equitable access to people who are good at procedures, they don't have the highest procedures. It's the academic medical systems, it's the large hospitals that have the largest number of procedures. And so the wealthy end up getting better care. If we can teach via virtual reality, we can increase the number of procedures everybody does globally. I can teach from here to Ghana and have them understand how to do a transcatheter aortic valve and practice it in the cath lab environment that we have created with one of our companies. And now they can actually get education from me thousands of miles away, and then we can even measure. Hey, you slow down every time at step 6. What's happening there? What are you not remembering? What do you not understand about that step? What's confusing you there? Let's get to that. So when you get to that in a patient, it'll be better. Do we know that in cardiology that is going to change outcomes? We don't yet. We're studying it. But we know in orthopedic surgery and other places where they've used this, it has improved outcomes because it makes the practitioner who's doing the procedure better. The one other place that things like virtual or augmented reality are helpful is thinking about urgent issues. So thinking about a code situation in a hospital. They don't happen often, but if you can practice, if you can simulate, then you get that adrenaline going and you learn to think through the adrenaline. And so there's simple ways from simulation and practice and mock codes that we've been doing for years that now we can layer in technology all the way to, here's a complicated new procedure. And instead of training people one at a time, we're going to train you all using virtual reality. So this new excellent procedure that is now FDA approved can get to more people sooner. So there's a spectrum, but it's exciting and it's growing.
A growing aging population means in the coming years we will experience a shortage of doctors. A study by the Association of American Medical Colleges predicts a shortfall of as many as 124,000 physicians by 2034 in the U.S. alone. That number includes medical specialties like cardiology. Dr. Bhatt says digital health will help the medical field address those growing needs.
This isn't just something confined to the United States. It's going to be worldwide, and actually it's going to have an impact on communities well beyond what we can imagine. Give me an idea of what this universe that we're describing looks like 5 years, 10 years out.
A few years ago, we had a conference in Dubai in the Middle East. It was a Middle Eastern cardiology conference. And a group of clinicians came up to me, introduced themselves. They were in Southeast Asia. They were physicians, nurses, and community health workers with not greater than a 7th grade education. They had developed a system where they could use ultrasound that had AI in it, artificial intelligence, to help community health workers take pregnant women and understand if their baby had severe heart disease or not. Simply by putting it on the belly, and then it would say, rotate this way, and it would turn green when you got the right image, and it would capture the image. These images are sent to the big city. We see who is really sick from not sick. We're not doing nuanced care. We're taking community health workers and we're figuring out who's really ill in this at-risk population. And then we bring just those individuals to the big city to be able to give both the mother and the child care, because otherwise maternal mortality, is through the roof in some of these areas. That doesn't only have to happen there. That can happen here in the States where our maternal mortality rates are exceedingly and embarrassingly high. So I think there are so many ways we can take community health workers, in whatever form you want to call that, and expand the number of people available to care for our growing disease population. We both have burnout, but we also just have a shortage. We have a shortage of clinicians that we're training after 8, 10, 12 years. We're working on shortening the training, but we're also working on saying, if you're someone who cares and wants to offer care, can we use technology to uptrain you so that you can start the process in the community? So those are the kind of things that we're seeing that we're really excited about.
That's a whole new world. Ami, thank you so much. Really appreciate it.
Thank you for having me.